All right, folks, welcome to today's webinar on Paying for Value, a discussion, a deeper dive on the 4 models associated with payment redesign under Healthier Washington. My name is Nathan Johnson. I'm going to be your webinar facilitator today. I also have the privilege of serving here at the Healthcare Authority as the Chief Policy Officer, and I'm coordinating the work of Healthier Washington. So it's really good to have such great participation today, and we are really looking forward to this discussion. Before we get into the substance and before I introduce the panel for you today, just want to walk you through a bit of logistics, if possible. First, there are 2 options for audio on your display. You can use your mic and speakers or your telephone. You can use the online question pane to submit questions during the webinar, and that is how we will be facilitating the Q&A process once the panelists are finished speaking. Our panelists will stay and answer questions at the end of this presentation, and we have quite a panel today, so I'm sure you will be interested in sticking around yourselves. So briefly then, as a segue, to today's presenters and panel. I'm going to start with our Secretary of Health, John Weisman, who leads the Department of Health and also serves in the Executive Governance Council for Healthier Washington. Dorothy Teeter, the Director of our Healthcare Authority, the executive sponsor of Healthier Washington and also a member of the executive governance for this work. Lou McDermott is our Division Director for the Public Employee Benefits Program and is here to cover primarily Model Test 3 and some work that is being done for a 2016 launch of a product. Mark Province is our HCA's Medicaid Transformation Manager. Rachel Quinn is a Special Assistant for HCA under Policy and Programs. And again, my name is Nathan, and I'm happy to be facilitating the discussion today. So just a brief few objectives for this webinar. And again, we will try to make our initial remarks and presentation as brief as possible to encourage your questions and engagement at the end of this. First, we do want to provide an overview of the state's Paying for Value strategy, which goes into a slightly greater depth than what you'll find in the grant application or other materials that are already available. We also want to give you a status report on this work because all 4 models are at different stages of development and implementation, and then, of course, get your feedback on that. We want to describe how Paying for Value supports other Healthier Washington strategies. This is important because all of the investment domains under Healthier Washington, whether you think of practice transformation, whether you think of analytics, interoperability, and measurement, whether you think of all of the programs taking place now, all of them are really sustained by changing the way we pay for healthcare on the front end, and that's what this discussion today is about. And finally, we want to engage in a dialogue and question and answer time with you and the leadership panel. So to that end, and without much further ado, I'm going to pass it off to John Weisman, who's going to kick this webinar off formally.
Great, thank you, Nathan, and thank you everybody for joining us. I think by now everybody who's on this call hopefully knows that Healthier Washington is really about achieving the triple aim, as you know, better health, better care, and lower costs. And hopefully you also realize that Healthier Washington is the whole health transformation we are trying to undertake here. Not trying, but actually are undertaking. It is certainly bigger than the State Innovation Models Grant, which is a huge part of this, but it is about how we're transforming healthcare and health in the state overall. So we're in this, in terms of the State Innovation Models Grant, we're in the pre-implementation year, as a reminder, of this 4-year initiative, which is truly bringing together hundreds of people across the state to improve the quality of life for everyone, regardless of their income, education, or background. So in addition to the State Innovation Models Grant, the $65 million grant, we're also looking, as you know, at a potential Medicaid waiver, and there's a document out for comment on that, and foundational legislation, which has set us up with essentially 3 of the main goals and strategies that we are undertaking. So as a quick reminder, the first one is that we'll see an engaged community driving local health innovation and partnering with the state on health purchasing. Our approach for doing that is through accountable communities of health throughout the state and using data to drive these community decisions and identifying and addressing community health disparities. The second goal is that we will ensure that people receive coordinated care for both physical and mental health and substance abuse in a way that works for that person wherever they are. And along these lines, we have goals of having the integrated physical and behavioral health care in regions as early as 2016 in the early adopter communities and statewide by 2020, and that we will spread and sustain effective clinical models of integration as we do this work. The third is that Healthier Washington will change how we pay for care so that we pay for the value of that care instead of the amount of care provided. This will shift us away, as you know, from a fee-for-service and reward quality. And as a purchaser of Apple Health, the Medicaid program, and state employees, driving the market towards value-based models is something that we have the ability to do at the state, and you'll be hearing certainly about our ability to do that as the first mover. The underpinning of all of these strategies, as you know, is to measure, improve, and report common statewide performance measures. So we want to show and demonstrate our accountability and have data that can tell us if we're on the right track. Make quality and price data transparent to inform consumers, purchasers, and providers, while ensuring we do this with a flexible workforce and that we've got active and engaged consumers. So we're looking forward to diving into the payment reform approaches, and with that, I'm going to turn it over to Dorothy.
Thanks very much, John. I, for one, can never stop being interested in the three strategies that we have for Healthier Washington, and appreciate John's reminder to all of us about what we're here today to learn about. Today, we're focusing on the third strategy, which is really what we call our paying for value strategy. While all the three of the strategies that John just outlined are necessary for us to transform the health system in the state of Washington, the pay for value strategy is absolutely essential if we're going to achieve the triple aim. We cannot improve health, clinical care, or drive down costs and improve the return on investment for the dollars that we do spend in health care without changing the way in which we pay for those services. When we say in our strategy that we want to improve how we pay for services, we really are talking about improving our payment methods so that it's easier and more clinically sensible to do the right thing. What we pay for and how we pay for it drives the way in which care is delivered. So if we want to ensure improved patient care and improved patient health, we need to reward those things, and that requires changing the way we pay for services. So if we can start, and this may be a primer for everyone, but I think it's a really good grounding so we can always remember what that acceleration point is that we're starting from as we move forward. So if we start with the predominant way that healthcare services are paid for today, we can say that health services are paid for on a per unit basis. So a price per visit, a price per patient day, a price per lab test. That translates then into the costs that we end up looking at in our cost trends for health services. So to project revenue if you're a health system, to measure cost trend if you're someone looking at the overall system. The simple math right now is the number of units that are paid times the price per unit is what translates into those financial trends. So fee-for-service reimbursement is the key driver that actually we could call it a key culprit, if you will, that leads us to reward, in a way, fragmented care. So, in a way, if you think about it, fee-for-service reimbursement really means that the more you pay for more units of service, the more expensive it gets and the more fragmented it is, so that we end up asking our health services organizations to make their money on increasing the fragmentation and increasing the volume of what they do without regard to whether it's necessary or not. So this is the current, but it's an outdated model that is seen by all of folks and experts in healthcare as the key driver for the cost growth in health services that simply has not been able to get under control. So with fee-for-service, there is little to no financial incentive to limit volume of services or to prevent a provider from performing a procedure, even if the service is not based in evidence or science, or if there's a less expensive option available. The incentives are really perverse in this way. Each provider is really paid for doing work in isolation on an episodic or one-on-one patient care visit, and no one is really right now paid specifically to coordinate care. And actually no one's being asked to hold themselves accountable for the coordination of care across the population of patients that they're serving. So this is the kind of current state. Very difficult to move, but we're going to move it in the state of Washington because we know that if we do a better job of paying for care, we can get better health outcomes and better cost trends and better quality and patient experience. So again, the dollars that we do have will get a greater return on investment. Cost and quality go together, and that there's no way in the future that we can disentangle those and have the success that we hope to get. So the new payment and delivery models are based on paying for value, not volume. And I know everybody's kind of sick of that term, paying for value, but it's really, we're dead serious about it, and it's the relationship of cost and quality, so that what you're paying for is the quality of the services that are evidence-based and necessary. We're not going to make any headway unless we move forward in this way. But it requires realigning the care delivery and payment incentives throughout our healthcare system. As we move forward to get reimbursing services based on quality and the evidence-based usefulness of the care that's provided, and not just the sheer volume of services, we are calling that paying for value, which is a little step away from paying for performance. Now we really want to move to paying for value. We are getting better as an industry in understanding the best ways to pay for and reward delivery systems that are taking the best care of people. And one last little comment here, which may seem obvious to everyone listening, but a key concept that underlines the new payment models is the idea that clinical teams are responsible for defined populations, and the financial cost and quality measures are measured with a denominator. So instead of a unit cost for a lab test, we're talking about rates of service per defined population or rates of immunization per defined population. So it's really moving our sets of measures as well as what we're paying for. So in the next slide, you'll see that there are different kinds of value-based payments depending on the level of risk and the degree of care of provider integration and ability to care for defined populations that organizations might have. To your very left is the fee-for-service system that we're in now, and you can see all the way to the right is a fully capitated model where delivery systems are then fully capable of taking care of and measuring results for defined populations. So this is a continuum. There are also ways within that continuum that you can get started. You don't have to go through each and every step along the way to get to the final shared risk kind of steps that we're looking at. We may never in this state get to full capitation, but I'm fairly comfortable we can get a lot of the delivery system who are already preparing to do this, moving to a shared risk model. They're interested in doing that. In 2014, the Healthcare Authority issued a request for information jointly with King County, and the purpose of that RFI was to assess the capability and intention of moving along this value-based continuum. Over 34 providers and payers responded, indicating they were getting ready, they were in this stream of moving forward, and they were ready to engage in terms of value-based purchasing arrangements. Next slide. So under Healthier Washington, as I mentioned, the Healthcare Authority is changing how we purchase care for Medicaid and public employees. We just simply could not sit back and say, well, the fee-for-service way is tough to change. Everybody's built their systems around it. We're moving forward and moving on to that because we purchase care in the state for 1 in 3 people in the state of Washington that are non-Medicare residents. So that equates to about 2 million people. The legislature has urged us on this way by providing a mandate through House Bill 2572 in the year 2014 to increase the use of value-based contracting, alternative quality contracting, and other payment incentives that promote the triple aim of quality, efficiency, cost savings, and health improvement for both Medicaid and for public employees. So our goal is to move 80% of state-financed health care to value-based purchasing arrangements and 50% of the commercial market by 2020. And just parenthetically, although we don't control Medicare, 50% of Medicare payments are also intended to move to this continuum by the end of 2018. So as a first mover, we're leveraging our power, and we intend throughout this, you'll see throughout the end of this year that we're going to be holding some conferences around that. And then finally, just to get a setup for the next set of speakers, there are these four payment models, models 1, 2, 3, and 4. You'll find that we call them different things. We're going to have speakers speak to each one of these. But model 3 is the accountable care program. We're using our testing with our PEB partners, including our partner with Regents, to test this concept of an accountable care network that is accountable for a defined population, working to move PEB members, public employee members, to that model from a fee-for-service model. Model number 4, also known as the multi-payer model, is focused on driving total cost of care and accountability around a shared data aggregation solution that effectively integrates finance and delivery. Again, you're going to hear more about all of these models coming right up. Model number 1 is the physical and behavioral health integration model, where we're testing the degree to which integrating financing within Medicaid can help both our physical and behavioral health services work better together with our providers to improve cost and quality outcomes for the population. And finally, model test 4, or what's called up on the screen as encounter-based to value-based, is introducing a value-based alternative payment methodology, again in Medicaid, for federally qualified health centers and rural health centers to pursue new flexibility in delivering care and using financial incentives for participating critical access hospitals. So I'm going to leave this here, except to say that at the end of 4 years, we fully intend to have Medicare, along with our commercial and Medicaid partners, fully engaged in this work. And I'm going to now turn it over to Lou McDermott, who's going to start us off with more detail about the models.
Thank you, Dorothy. The PEB program, the Public Employees Benefits Program, serves about 340,000 members, which range from state employees to higher ed to pre-Medicare retirees to Medicare retirees to political subdivisions. For test model 3, we are going to be doing an accountable care program, which will launch on 1/1/16. The goals of the program were to provide a best-in-class patient experience, access to high quality and timely service at lower costs to our members. We want to deliver integrated physical, mental health, and substance abuse services, and also one goal is to assume financial and clinical accountability for the delivery system for the defined population of our PEB members. We embarked on this journey in the fall and have finally settled on 2 delivery systems we are contracting with. One is the UW Medicine Accountable Care Network, and one is the Puget Sound High Value Network, which is led by Virginia Mason Medical Center, Evergreen Health Partners and Hospital, and Multicare. In the future, we would like this product to expand either by bringing on new delivery systems or expanding the partners who we contract with inside of the UW and the High Value Network. Some of the mechanics of how the ACP program works. We're going to be offering, in the contract, we're having patient-centered medical homes. There's language in the contract which drives towards patient-centered medical homes. There's IT sharing requirements. There's BRE recommendations, which we're asking and requiring that the High Value Network and UW ACO implement. We're also doing shared decision-making. We've expanded hours for our members. We have dedicated contact centers for each of the delivery systems, websites so you can go and find providers and other information. We're trying to coordinate the electronic health record in that website so that folks can go in and take a look at test results, their labs, communicate with their providers, all the enhancements we would expect in a product like this. The financial model is a unique model which incorporates both the financial aspect of a total cost of care scenario mixed with quality measures. So quality is a huge part of how the contract works. If there is upside or downside savings or deficit that needs to be paid or received, the quality will have an impact on that. So, for example, if someone were to meet their financial goals, if one of the entities meets their financial goals but its quality is not shown to be where it should be at, they will receive less of a financial incentive, and vice versa. The ACPs, they're going to be a big part of it is going to be coordinating data. We're using our TPA to coordinate all the data for the members so that the ACPs have a full working view of our members and where they're receiving services, what type of services, what type of medication, all the information they need to manage the account. The product will be offered right now in King, Pierce, Snohomish, Kitsap, and Thurston. We're going to be offering benefit design changes that will encourage members to utilize the product. We're going to have lower premiums. We're trying to make primary care free, so no charge for primary care visits. We are looking at no deductible for pharmacy and a few other benefit design enhancements. That's about it for Test Model 3. Test Model 4, Rachel Quinn is going to go over.
Thank you, Lou. Good afternoon. Model 4 is what we call the Greater Washington Multi-Payer Fully Insured Test Model. And I'm going to give a short overview today, but I'd like to point out that this is the least developed of the 4 models at this point in time. Model 4 strategy is laid out in the Healthier Washington grant application, focuses on engaging multiple payers and provider systems with a common interest towards accelerating value-based payments strategies around a shared data aggregation solution. Right now, some providers and provider organizations are unable to take on new value-based payment strategies and population health management responsibilities without a unified view of their patients across multiple payers, which requires integrated clinical and claims data. To implement Model 4, the Healthcare Authority intends to identify a partner organization with expertise, proven expertise and capacity to convene payers and providers to drive accountability and value-based payments around an existing common data infrastructure solution and align with other Healthier Washington initiatives such as the statewide core measure set. The Healthcare Authority will support this partner organization by providing and committing resources, data, and financial support over the term of the grant. The Healthcare Authority plans to release more detail on this model soon, so please watch for an announcement through the Healthier Washington Feedback Network. I'd like to introduce Mark, who will now present Model 1 and 2.
Thanks, Rachel. One of the principal components of the vision for Healthier Washington is that physical, behavioral, and substance use problems rarely occur in isolation. Yet our current system, as Dorothy pointed out earlier, typically organizes and pays for those services separately. Under the vision of Healthier Washington, there will be an integrated physical and behavioral health combination of services offered that serve really the whole person. And one of the principal areas of focus for Model 1 is on this integration. The governor's vision, together with the historic legislation that was passed under Senate Bill 6312, and really the whole Healthier Washington plan, provides the critical underpinnings for a transition from this fragmented system toward a more fully integrated managed care system, with particular focus on the Medicaid population and ultimately moving us in this direction statewide in 2020. Under this vision, there are really 2 paths to get to that goal of fully integrated care by 2020. On the one hand, and as noted on the left-hand side of the slide, we have a combination in a number of service areas, and we'll show you a map on the next slide, in which our Apple Health managed care plans, together with behavioral health organizations, will operate really hand-in-hand to integrate services for physical, behavioral, and substance abuse services. I'd like to call your attention to the right-hand side of the slide, where we talk about integrated purchasing in early adopter regions. The idea here being that we will deliver integrated behavioral health and physical health services under managed care contracts. And actually, if we can move to the next slide, our first early adopter region is Southwest Washington, where in Clark and Skamania counties, we'll deliver those services on an integrated basis under managed care in concert with a regional crisis system that will be procured under a separate arrangement. These activities will be monitored using performance measures that really are in concert with the larger scope of performance measures that we've identified to identify particular important outcomes for behavioral health and physical health integration. In the remaining counties, those are the areas in which we will have both our Apple Health managed care contracts and the behavioral health organizations operating in concert. On the next slide, it gives you a sense of what the timetable is under this test model 1. Next week, we are scheduled to release an RFP in Southwest Washington, request for proposals for the integrated managed care contract, with the target of announcing successful bidders in November. And together with the contract for crisis services and the draft contract for that arrangement will be released next week as well, with an RFP to follow in September. All of these arrangements for Southwest Washington are targeted to start April 1 of 2016. Moving to what we call Model Test 2, which is really our move from encounter to value-based payment system for the providers indicated here: federally qualified health centers, rural health clinics, and critical access hospitals. Over 41% of current Medicaid beneficiaries in Washington, and actually 1 in 10 Washingtonians, are served in a federally qualified health center or rural health clinic. And most of rural Washington is served by federally designated critical access hospitals. Although these providers offer some of the most innovative and integrated delivery models in the state, the reimbursement models under which they're working can frequently act to impede innovation because they're tied back to that volume-based, fee-for-service-based delivery system, which really doesn't allow the kind of flexibility we're looking for not only integration of services, but really creative delivery of care and integration of care with the rest of the community. And some of the challenges that these essential providers are up against are indicated here on this slide. There are statutory and regulatory barriers, for example, tied to the limits under which a hospital may need to work given its critical access hospital license. The payment models are still very much encounter-driven, and the reimbursement is on a cost basis. So again, this aligns back to what Dorothy was talking about earlier with the kinds of incentives that can frequently operate as disincentives to really integrate care. So for the federally qualified health centers and rural health clinics, we're working in tandem with those providers really to take advantage of the kind of team-based care that they currently provide, to move them from a volume-based reimbursement system to a value-based system. We have strong support from the clinics. We're working with them as partners. We've established good working relationships with them. We're also looking at APM stands for alternative payment model in that last bullet. We're looking at alternative payment model approaches that are being taken in other states to see what we can learn from their experience as well. And finally, with respect to the critical access hospitals, once again, we're working closely with them and also with the Washington Rural Health Access Preservation Initiative, which is an initiative between the Washington State Hospital Association and the Department of Health. There are between 11 and 14 critical access hospitals that have been identified for potential testing of a model that, again, would allow them the kind of flexibility that we're looking for to kind of realign their services with the needs of the community in such a way, and compensate for them in such a way that really encourages innovation. And we've already started to receive feedback from individual hospitals confirming their willingness and interest to work with us. So at this point, I'd like to transition back to John for the comments.
Great, thanks so much, Mark. So again, next slide, really we are talking about foundational elements to all of this and the approach we're going to take. You can see on the triangle here the various components. We obviously have done a lot of work in the state already on the common measure set. We have that. We're looking for folks to really focus on that as our focus on outcomes and what all parts of the system we want to deliver on. The engaged consumer is incredibly important in looking at shared decision-making approaches. And I must say, as someone who just had a healthcare encounter where we actually did shared decision-making, probably not formally, it felt really good. I came out as a patient who was like really happy. So I'm plug in for that personally. Then the clinical practice transformation that's going to need to occur and all of the work around the hub. And then looking at the transparent price and quality information with the all payers claim database work. So many components to this to make all of this work and to help measure our progress and frankly to help people be successful. We certainly see that as one of our roles here. How can we help everyone in this transformation? We know that it's large in scale, but essential, as Dorothy said. And certainly, the payment redesign is absolutely essential to make this happen. Without payment redesign, we cannot actually achieve the goals that we are looking for. So this picture, for those of you who like graphics and can remind you of the various components, is hopefully a handy tool for you. And just to remember, by 2019, we are really looking to shift 80% of the healthcare purchasing in Washington State from paying for volume to paying for value. I think Dorothy might have mentioned that at the beginning. We're also looking to have this integrated physical and behavioral health services in Medicaid that serves the whole person, and remembering that our minds and the heads are connected to the rest of our body, and to see engaged communities driving local health innovation and partnering with the state on health purchasing. If we're going to really achieve health in the broadest sense in population, this is about bringing together folks across sectors, getting rid of the divide between healthcare, public health, human services, and really looking at all of our resources together. So 2015 is the year when we begin this heavy lifting of moving away from this fragmented, bifurcated system to one that is a person-focused and well-coordinated system, and I think one, frankly, that consumers are looking to have. So with that, I'm going to turn it over to Nathan to do the wrap-up.
Thanks, John, and other presenters. I hope those of you listening in have now a better sense for the four models around payment redesign and how they're very much linked to the other priorities and initiatives of Healthier Washington. As John, Dorothy, and others have communicated to you today, it's our fundamental belief under the Healthier Washington program that we cannot sustain the level of health transformation necessary to serve Washingtonians well without changing the way we actually pay for healthcare services. And so all of this work is critical, and even as it does start in some ways with state purchasing, the absolute intent is to expand it over the course of this project to other payers, be they Medicare, commercial, or otherwise. So now I think we have reserved the balance of this time for questions and further dialogue on this. Some of you have already submitted questions. We're theming those as they come in. And as a reminder, your panelists and folks you can direct these questions to: John Weisman, again, our Secretary of Health; Dorothy Teeter, who you heard from, who is our Director of the Healthcare Authority; Lou McDermott, who runs the PEP program; Mark Province, our Medicaid Transformation Manager; and Rachel Quinn, our Special Assistant for Policy and Programs. So thank you all for the presentation, and now we look forward to your questions, comments, and further follow-up.
So Nathan, we've received a few questions about the geographic reach for these four payment models. Particularly, Lou mentioned the counties that are covered in the ACP. Folks would like you to hear what those are again, but also what's the reach for multi-payer, as well as the two Medicaid-focused models.
For the ACP products, right now we're looking at King, Pierce, Kitsap, and Thurston. In subsequent years, we're hoping to expand that, obviously, statewide. We're working with our partners to see how much they can do within their own system and acquiring other delivery systems and other partners. And there's also the opportunity to sign additional ACP contracts with networks. So that'll expand based on their coverage area.
And just briefly, I'll speak to the other payment models. Model 1, as Mark indicated, is starting in terms of full integration of physical and behavioral health in Southwest Washington. I think one of the maps that we had on the slides indicated that. That, too, is a statewide expansion with a legislative mandate to have it expanded by 2020. But we do see it expanding in the intervening period year by year, and are going to be working very hard on that. Model 2 actually is addressing a delivery system that spans the entire state. We have federally qualified health centers in both urban and rural settings, rural health clinics and critical access hospitals primarily in rural settings. The types of payment models and changes we're talking about will have statewide impact, even as clinics and hospitals will decide for themselves on a voluntary basis whether or not to participate. As Rachel expressed, Model 4 is still in the development stage, and it will depend by virtue of the responses to the request document that will go out shortly as to the geographic reach of that particular approach. As the grant application indicated, and as the headline for this model would suggest, the intent is to focus on Greater Washington. So while we have Model 3 really being established and started in the Puget Sound region, we want to make sure we are addressing the need for accountable care methodologies and infrastructure both east of the mountains and in other more rural areas of the state. So that is our focus, although not exclusive, is our focus of Model 4. So I hope that gives people a sense of geographic stretch.
We've received several questions about Payment Model 1 and the integration of physical and behavioral health care, particularly around the transition. So folks are asking about sort of how roles will shift around the behavioral health organizations, our managed care organizations, and also what support will be provided as this shift happens. What will that transition look like in order to get to the 2020 vision?
Well, given that we're already underway in Southwest Washington, that probably serves as a good model to suggest how we'll approach this statewide. We've been working very closely with a group of folks who are from the community, both behavioral health care providers and, if you will, physical health care providers from Southwest Washington, from the two counties indicated on the slide. So our activity really with them is to make sure that this transition actually is a smooth one. Involved, for example, in the discussions are individuals who have been working with the RSN, the Regional Support Network in Southwest Washington, as I mentioned, behavioral health providers, crisis health providers. So it really is a collaborative effort. The services, the integrated services we'll be delivering there, again, will be delivered through managed care contract. As I mentioned, the RFP for that activity will go out next week. So that document will provide, I think, perhaps a deeper look, if you will, into how we're approaching this integration. So it really is, I think we've taken great pains to include and involve all of the participants who either will be direct providers or would be affected by this transition, including county governments too.
John, in particular, spoke to a lot of the other investments and mechanisms that we have in place under Healthier Washington. We got several questions about how we were focused today in the integration, kind of the de-siloing of financing mechanisms, but how will other services be folded into this holistic approach? So food, shelter, employment.
This is Nathan. I might take a first stab at this. It's a great question, and I think it speaks to one of the fundamentals of Healthier Washington, which is a recognition that health improvement for people, for real people, is a story about way, way more than just what happens in the healthcare delivery system. Admittedly, today we're zooming in. We're zooming into how we pay for services in that healthcare delivery system, but there's much broader structures that are supporting the health transformation effort. Specifically, I would call your attention to the accountable communities of health which are the table, are the place within communities themselves where multiple sectors of the nature that the questioner proposed are gathering together to discuss both what happens within the healthcare delivery system and how what happens in the healthcare delivery system can be better connected to community assets, be they related to food security, housing assistance, education, faith-based organizations, or otherwise. That is very much a work in progress, and I'm very excited to announce, although the announcement already occurred, but we did designate formally our first 2 accountable communities of health who are now serving in that capacity within our state. That includes the North Sound Accountable Community of Health, which is 5-county region starting in Snohomish and going northward, as well as the Cascade Pacific Action Alliance, which is in southwest, not quite southwest, but central Washington, south central Washington, however I frame that, and includes 7 counties, including Thurston County, where we are today presenting from. So a lot of work in that arena, and then furthermore, in terms of the financial pieces, as we envision value-based purchasing going forward, it's a lot more, as Dorothy and others have suggested, a lot more than how we actually just reimburse for those clinical services, but how we incentivize other behaviors related to clinical and community linkages, especially. So more to come on that front, and a lot of work, most importantly, being done at the community level to figure this out. And I think that partnership between the state and the community is most important here. I might look to Dorothy and John for any additional comments.
Nathan, I thought that was really well said. I think also as we look at other funding we have at the state, as we look to get work done, we'll be looking at how can we encourage collaboration and coordination, if not direct to outright engagement with the accountable communities of health. So we'll be looking at other funding systems as well and looking at regional approaches to that. Now for my public health colleagues who have just thrown off the edge, I will also add in here that I certainly know that we have health departments that provide critical services. We call them foundational public health services, and we're certainly looking to make sure that we adequately fund those, which we don't right now, as part of this whole health system and how truly we all need each other to achieve population health.
The only other thing I would add, this is Dorothy, is that we've structured this whole approach on purpose to engage many of the different agencies, at least at the state level, so that we can understand all of those systems, housing, food security, public health, healthcare, all together to see how we can really work to improve the health of the population by leveraging all those different funds. So the leadership and the governance of this overall approach is really being driven at the request of the governor from many different state agencies working together. So between the linkages, the community with the state and the state linking together, understanding the fantastic work that's already gone on with public health in particular, I think we're going to be really moving forward to make sure we've got those systems working properly and as well funded as we can.
We've talked about accountable communities of health. Folks are asking about the accountable community of health role in this transition to paying for value, particularly expectations around partnership with the state and with payers throughout the state as well. Nathan, you did a brief overview of what an accountable community of health is, but it might warrant some further explanation before we get into their specific role, particularly in purchasing.
Sure. And I'll be brief and then turn it over to others who might want to fill in here. Under Healthier Washington, accountable communities of health are those regionally based collaboratives that are bringing together sectors that influence health, whether they're in the healthcare sector as we would traditionally think of it, or more on the, if you will, social determinant side of overall health improvement. This is based in actually in some cases a multi-decade tradition of more loosely formed coalitions in this that have occurred in a way across the state. And actually, as part of our innovation planning process, we learned a lot about those efforts, about where they thought they were being successful and where they thought they were missing something. And one of the things we heard loud and clear from our community partners is it sure be great if the state would engage us a little more directly. And given how much money the state spends on healthcare services, it sure be nice to be treated as a partner in some of those discussions going forward. And what you see reflected in the innovation plan, ultimately in the grant application now under the Healthier Washington initiative, is a reflection of that conversation and what we heard pretty loud and clear, which is to be effective in our purchasing efforts, we actually need true community partnerships that are driving innovation to the most local level possible, even as we take accountability for our own purchasing policies, ensuring that we ourselves are buying for value. Getting a little more specific about things, the accountable communities of health role in purchasing may look different depending on what community we're in, but there are some pretty basic factors. One, we do expect and have seen throughout the state the significant and appropriate role of payers at the accountable community of health table. So one of the ways you ensure that level of collaboration is ensuring that the membership and decision-making and governance of accountable communities of health are truly reflective of the community responsible for delivering on overall health needs. So one way that accountable communities of health in some respects, whether they're formally designated or not, are already serving in that capacity is by virtue of who they're including at the table. This state does the vast majority of its purchasing through health plans, and those health plans and their involvement in community activities is something we are stressing and as appropriate dictating in contracts. The other thing we foresee is we've just described to you some of the payment redesign efforts, and there are other multitude of efforts, as those of you on this call likely know, in the arena of Healthier Washington. One thing we see accountable communities of health absolutely doing is playing a role in some of the very disruptive elements that we're setting forth that at their core are innovative and proven, but take a very heavy lift, and we're quite aware on the state side that lift needs to occur in partnership with the community. And accountable communities of health can be a partner in some of the purchasing overhaul that is underway. And in fact, just as Mark described with some of the local implementation efforts associated with early adopter integration, I think you're seeing that play out both with county government and the broader community of providers, social service providers, and other community-based organizations. So there are some specific examples of that role and partnership in purchasing that we foresee, and I think Dorothy might have some thoughts to add as well.
Yeah, those are fantastic examples, and I think if you look at it from the perspective of a delivery system that's now contracting in a new way for paying for value, and one of the measures, for example, that they're going to be rewarded for achieving is a decrease, this is just an example, of avoidable emergency room visits. Or another example might be ensuring that all the patients in their population have their blood pressure under good control. Where the structure of the ACH can work in tremendous partnership with the care delivery system and also with the payers is to work with the ACHs and say, can you help us understand what the access problems are in this community that are causing people to go to the emergency room for unnecessary visits? Or can we work with our local EMS system to do visits for folks that are having trouble with hypertension and have folks help them in their homes to manage that? So there are these direct dots that can now get connected between the clinical care system and the community, and we're hoping that the ACH can play a pivotal role along with the Transformation Hub in ensuring that that works all well together. So again, I think this key concept of defined populations, improving health quality and cost experience for those folks really drives towards understanding what the assets are in a community as well as in a healthcare delivery system and other parts of the health system like public health to see if we can leverage all of that together to get to those measures that and the outcomes that we need.
We have a lot of questions around how we are defining and measuring value, and also what access to cost, quality, and outcomes data we'll have in order to measure this movement toward value, and also how we are, this is a multi-pronged question, how we are monitoring for unintended consequences, such as de-incentivizing providing care to clients who are expected to have poor outcome measures.
might give us just a quick global response to those, and then have some others on our team respond. First, on the question of how we're measuring value, there's, of course, the basic premise of quality increasing and the costs or the rate of cost inflation going down. And if both of those things are happening at the same time, that is the value proposition on a very high-level scale that we're after. But more concretely and more importantly, this state, as I believe Dorothy or John covered in one of the slides, has already gained tremendous consensus around core measures of health performance. That work was done with a governor-appointed committee towards the end of last year and resulted in the definition of 52 core statewide measures of what we think it means to be achieving more value in our healthcare system. So if you had asked me today how we are defining value, both at the global level of improved quality and lower cost, and then by virtue of exactly how those measures will play out, there was a further question of the data components that's obviously critical here. And one of the important elements of that work to define core measures is we started with measures for which we have data. And one of our key and lead partners in this work is the Washington Health Alliance, which is building on the data sets it already has at its disposal to produce measure sets consistent with the defined 52 core measures. And they're working not just in their own domain, but with other partners to achieve that over a very short turnaround. The other commitment we have under Healthier Washington for how folks at a local level will be measuring their own success is maybe not to perfect, but to get into the game at least of data dissemination, whether we're talking about public health data sets in aggregate form or data sets related to our own state health purchasing. We have not been as in front of the game as we need to with getting at least aggregate level data to communities so they can measure their own success, and we're working very hard on some interim solutions for that. And finally, with unintended consequences, and Dorothy might want to say more about this in particular, we've really embraced the notion of rapid cycle evaluation and have built that into all of our evaluation contracts to ensure that we're not just evaluating this thing 2 years after Healthier Washington is done, but the evaluation is a constant, meaning that as we need to make course corrections or changes in how we're designing value-based payment or how we're measuring it, we will have, I think, some of the state's strongest and best expertise helping us do that here as part of the Healthier Washington project. So that's at a high level, and maybe John or Dorothy or others on our team would like to add. Mark, go for it.
Oh, I was just going to add an example. It's something I was impressed by as I was becoming familiar with what's happening in Southwest Washington, and that is that the group there, in addition to planning for this transition to fully integrated care, has actually been paying attention to what are the risks involved in making this step, and what do we anticipate, and how can we make sure that we address those up front or have a way of addressing those so that when we get there, we're not all of a sudden caught by surprise by something happening that we didn't intend. So it's a very local example, but the fact that the community really that we're working with came up with that approach, I think, was very indicative of what we hope others will embrace when we talk about making this move to value.
Great, Mark. Any others?
Yeah, it's Lou McDermott. For the ACPs, we do have 19 quality measures that we're looking at in areas as chronic conditions, behavioral health management, patient experience, medical screening, immunizations, C-section rates. And as with any contract, we're going to be working very, very closely with the delivery systems, looking at those measures. And if we do find that the way the contract is constructed, that we are having unintended consequences, I think it's an opportunity to come at the table and to modify the contract and make sure we make adjustments to it. Contract is a living, breathing thing. Many contracts have tons of amendments on them as time goes by, as you realize that you were asking for X and you sort of got Y. So we will be working with our partners very closely and making sure that the product is working the way we intend it to and make necessary adjustments along the way.
One more, this is Dorothy. One thing that Lou just made me think about, along with what Mark's and Nathan's comments, is that part of this whole approach with rapid cycle measurement and improvement is that we also share what is not working as well as what is. So through the Transformation Hub and through the ACHs working together, through our delivery systems connecting, and our payers, we will be looking as much as, oh, we thought this was a great approach, but it's really not working as much as we are what is being successful. So we can, again, accelerate what is working and leave the rest behind. And the other kind of different angle on that question that I might have heard was, how do we ensure that the most vulnerable populations that we're taking care of in this transformation come right along with us? And I think there's been a tremendous amount of work internally to ensure that we are looking at different population segments to make sure that that does not happen, because some of the approaches that you take with one population may not work for another. So we will be definitely monitoring this at that disaggregated population level as well.
This is John Wiesman. Just to also, I think, remind all of us, we expect we'll have to do some course corrections as we go. But also, you know, if we ask ourselves, what are the unintended consequences of the system we currently have, to remind us that we are actually about trying to change the things that we have now, where we have huge health disparities, where we have people who are getting mental health maybe treated separate from physical care, no integration, no real, you know, we're getting more service than we need. So there are unintended consequences with what we have right now. I just want to remind us of that, and we'll be really paying attention to, are we changing that, that environment.
We focused today on the 4 payment models that look at integration, FQHCs, RHCs, critical access hospitals, and PEB. How are we anticipating or planning to spread this movement toward value throughout the state and reach beyond these 4 payment models?
This is Rachel Quinn. Under the Accountable Care Program Model 3, as we laid out in the Healthier Washington grant, and it's called a Puget Sound multi-purchaser test model. Once we get the Accountable Care Program off the ground for state employees in 2016, in tandem, we're also planning and working with other purchasers to emulate the model that we've adopted throughout the state for them to adopt in 2017, and also help them adopt additional value-based purchasing strategies as well, in partnership with the Washington Health Alliance.
One other thing I would say is one of the unique opportunities under the State Innovation Model Program is a new willingness from Medicare to work more closely with states on state-designed innovations. So there are some opportunities, especially when we look at Model 2, for Medicare participation. What remains to be seen is the level of participation we can get there, but it'd be worth noting that especially in the case of critical access hospitals, it is very hard to make the level of change that we're discussing here with a Medicaid exclusive approach. So whether it's the need for data to support the reimbursement changes or actual wholesale transformation of how Medicare itself pays for services, that is the opportunity here under the State Innovation Model Program, and something our federal partners have been pretty clear about, and something we're going to have to test their readiness for as we go through this project.
Our final question today is how our partners who are on the phone and not on the webinar today as well, those who are interested, how can they engage in conversations and be informed and be part of the conversation around each of these 4 payment models?
I might have each of our payment model leads talk about that from their perspective, maybe starting with Lou on Model 3. And following the work of the PEB board and such.
Yeah, on Model 3 through PEB, we have a public meeting that takes place, the PEB board, where this model was discussed. The details of the model was brought before the board, and they'll be voting on August 6th. And so there will be a final resolution vote to enact the program effective 1/1/16. There's a website on HCA. If you get to the PEB website and see the board, you can see all the board materials that have been presented over the year. They'll have all the information about the program as we have presented it to the board. Also on the PEB website, there'll be communications that are going to be developed between now and November. November is our open enrollment period.
So between now and November, we'll be communicating with our members, explaining to them what it is and explaining the details of the plan as they become available.
Mark, if you'd speak to Model Test 1 and 2.
This is Mark. For Model Test 1, again, our concentration for the fully integrated model has been in Southwest Washington. And as I mentioned, we will be releasing both the RFP for the fully integrated managed care contract next week, along with the draft agreement for the crisis service agreement as well. So those documents will be available on a link through the website. With regard to Model 2 and our work with the federally qualified health centers and rural health centers, excuse me, critical access hospitals, there's that work probably isn't quite as far advanced. I think there's information generally available through our website on the direction in which we're going, but I think what I'll do as a result of this question is go back and check and make sure that we've got all of the appropriate documents that we have so far linkable on that site. That's my homework.
And this is Rachel. In closing, for Model 4, kind of like Model 2, we're not as far along as 3 and 1, but an upcoming announcement will emphasize that under Model 4, we really want to work with a lead organization and other payers and providers that are committed to implementing value-based purchasing and alternative payment models, and committed to working together to get additional integrated claims and clinical data to providers to enable them to take on more risk and enable additional or expansion of population health management capabilities.
Thanks, team. And I'll just point out that the slide in front of you provides an email list that you can send a quick email to and be signed up for the email list, which gives fairly frequent updates on a host of Healthier Washington initiatives. And I do believe, although we're still making improvements to it, that the website is a great place to access some pretty key materials, including one-pagers that discuss some of the topics we've covered today that may be less familiar to some of you. Please do go check out that website, and if you see anything missing there, would you let us know, and we'll try to fill in those cracks. We want as much involvement and participation, and certainly need that for these activities to be successful, given their far-reaching nature. I think that's all for us. I don't know if Dorothy or John want to wrap this up.
Nathan, that rang a bell. There is also on that website, you can go to the PEB portion and you'll see a distribution list you can sign up for. So whenever board materials are sent out, you'll automatically be sent those materials.
Great. Thanks, Lou.
I think on behalf of this entire team that's on this webinar, we want to say thank you for participating and reiterate what you've just heard from everyone. If you have comments, questions, you know where to find us. Please do, and we will respond to any questions that you have.
Thanks so much.